various facets. And we are extremely fortunate to have with us Dr. Sakthi Karunanithi today. But before we introduce him, may I request the Secretary of the Global Alumni, Dr. Madhu Sairam, to give a report, and then we will proceed to introducing Dr. Sakthi Karan. Dr. Madhu Sairam, please. Dr. Madhu, can you?
Am I audible? Okay. However, management will be able to implement it. In fact, following the talk by Dr. Sakthi, this test, etc. And I have something more interesting to mention that on Jan 8, 2023, which is a Sunday, I would request you all to block the dates because it will be 1 year since the current office bearers took over, and we'll have a great get together somewhere around in Coimbatore. And Dr. Sakthi, we all missed your talk in Ganga Hospital sometime back when you were in India, and like most others, I'm eagerly awaiting to listen to you. Over to Dr. Balavenkat. Thank you so much.
Thank you, Dr. Madhu Sairam, for coming in spite of being in a meeting in Chennai. This shows the commitment to the cause. Thank you for being with us. And it's indeed a great pleasure to introduce the speaker of the day, the 1995 batch from Coimbatore Medical College. I had the fortune to meet him and listen to him while he was in Coimbatore. Absolutely fascinating and excellent work that he is doing. And I also liked the content of his talk, the way he delivered, the diction, and he's a perfect speaker. And I'm sure, Dr. Sakthi Karan, there are many things that are in the offing for you, including possibly becoming the Prime Minister of UK. So Dr. Sakthi Karunanithi is an experienced public health director with a demonstrable history of working in the NHS, local government and industry. Shakti's breadth of knowledge covers population health management, evidence-based policy advice, epidemiology, prevention, health promotion, healthcare management, and Sakthi has an active interest in insightful system leadership and innovation. During the COVID pandemic, he has chaired the Joint Intelligence and Planning Group to support the management of COVID-19 pandemic across Lancashire. He has also an experienced clinician with a demonstrable history of working in the NHS, local government and industry. He has led the population health management and digital health programs across the Lancashire, and he's currently supporting the national NHSC system transformation team in delivering the place development program. So he has got several insights in his holistic way he has grown, and he wants to contribute phenomenally to public health and healthcare. And he's also gone very spiritual. And we have a combination of a doctor, a great human being, and an excellent communicator, orator, Dr. Sakthi Karunanithi. And he's going to speak on a very fascinating topic, which would benefit all of us. Over to Dr. Sakthi Karan. And I take this opportunity to thank Fujifilm Sonasite on behalf of all the doctors present here. Thank you, Sabita, for giving us the platform and being so precise in what you do. Over to Dr. Sakthi Karan.
Thank you very much, Dr. Balavenkat. It's been a pleasure to meet some of you when I was in India last month. And I am taking so much from even preparing for this this webinar. And it's a real pleasure to be back in touch with the alma mater and to be able to contribute something that I hope will trigger some thoughts today and expose you to some of the things that we're doing in the UK on this subject, and hopefully it will introduce you to some new things that you can try in your own day-to-day practice. I have got about 25 minutes, Dr. Balavenkat, am I right? I'll just adjust my time accordingly.
Yeah, actually 30-35 minutes is fine. Yeah.
Okay, great. So I particularly chose this topic because I thought this will stimulate more thinking than provide us with solid answers. And in a way, I just wanted to circle around even the heading of this this webinar for a minute or two. And this has been really something that has been bothering me for some years, since I actually got qualified in CMC, and particularly I was really interested in social and preventative medicine, although I also wanted to become a surgeon, and that's a completely different story. But there has not been a satisfactory answer to this for me so far. And if you think about, is our health really in our hands, and try and answer it as either yes or no, and pursue justifying that answer, you'll end up with the opposite of where you started with. So I'll give you an example or two of all these things that will be familiar to us, whether that is an acute cardiac event, a road traffic accident, mental health, very important subject that we're dealing with, or indeed cancer or infectious diseases like polio, but more recently COVID. If you think about, is having a heart attack really in our hands, and you start with the answer of yes, which means, yeah, I could have smoked less or been more active. And then if you think about, why did I smoke, and why did I not do enough exercise, for example, or indeed, why did I not have my blood pressure under control? It becomes very apparent that, take smoking, the first fag is always a free fag from somebody that's very close to us, perhaps our friends. The reason why we may not have done enough exercise is probably because of our workload, which may be because of the demand that's coming through our doors. So although you start with an answer of yes, I am responsible for my health, you soon find out that actually there's a lot of other people involved in it, and my health is dependent on other people, and often the environment in which we live in, be that heart disease, be that road traffic accidents, and we've recently seen COVID. However much we've tried to avoid getting COVID, we still couldn't prevent everyone getting COVID, if you see what I mean. So it has been a paradox for me, and that's one of the reasons why public health medicine, which I practice, I got qualified in public health in India, actually, in 2002 to 2004, and then we moved into UK, and I got certified in public health medicine here, and practicing as a director of public health. So when Dr. Balavenkat introduced me this idea of, oh, would you be willing to present on a topic, this was something that really jumped out of my head. And I really do think we often tend to see health as within the walls of our clinic or operating theater. And increasingly, it is becoming very apparent that our health is probably in our hands, but also not probably entirely in our hands. And that's the subject I wanted to explore with you all this morning. And this all started really when we started understanding more about what determines our health. And quite often I used to treat people, and I was working in Munnar. That's where my medical practice actually started after graduating. And then I moved to Delhi, and then have come to the UK. Quite often we write prescriptions or perform procedures and send back people to the conditions in which they've already been living in without much of a change in the environment. And this has been a proven fact, right? About 2/3, and this is from WHO, a long time ago actually, about 2/3 of our non-communicable diseases, which is on the rise, is basically contributed by these 4 factors: tobacco, harmful use of alcohol, unhealthy eating, and not being really very physically active. But if you take each one of them separately and try to answer the question, is our health really in our hands? What we are really trying to answer there is, if you think a bit deeply about this, do we have free will? And do we have choice to be healthy or not? And that's quite a deeper question to explore. And in our day-to-day practice, in the busyness of our medical practice, our daily lives, we often don't get a chance to explore these factors a bit more. And working in public health as a trade, you do get trained in these things, and it's been a real eye-opener for me personally, as you try and unpack what actually determines our health. The more and more you do that, the more and more one realizes there's a lot of things that are probably in our hands as a collective society, by human beings working across various agencies, and not necessarily all of that is in the hands of doctors and nurses, or indeed health sector in its broadest sense. So not really giving away an answer as such, but exposing the complexity of what actually determines health has been an important theme for me personally, and I am interested how you all approach this in your day-to-day practice. I am pretty sure a lot of you have dealt with these things, but how you've structured your thinking, I'm hoping this webinar will help you think through that a bit more. And this is the place that I deal with, Lancashire. It's near Manchester in England. And one of the things I do in my day-to-day job is to produce a report every year, and it is by statute, by law. Every director of public health needs to describe what is going on in their community, what's actually determining the health of their community, and then we need to try and take steps to improve that. And quite often we deal with averages, and I just wanted to highlight something else which is on this slide, and that is about variation and not just averages. And you'll see this in everyday practice, whether you're doing audits or doing surveys. And for us, we hold ourselves to 2 key metrics, if you will. One is the life expectancy, which is how long one is expected to live. And the other one is inequalities in life expectancy, which is the variation in how long one is expected to live. But within that, we also look at healthy life expectancy. If I just stay on that for a minute or two, life expectancy in Lancashire at birth for women is about 82 years on average. And for men, it's slightly lower, 78 years. But when you look at the healthy life expectancy, and that is how long a baby girl born these days is expected to live in good health compared to how long they can live, it's about 20 years less than how long one is expected to live. So roughly speaking, if one is expected to live till 80 years, around 60 years they can live are expected to live in good health, and the other 20 years is not so good health. And that means nearly a quarter of someone's life is going to be a little bit miserable, either in pain or disease or discomfort or disability. And that's got a lot of implications in terms of the local economy, let alone just how one suffers from disease, which in itself is an endpoint. And just to give you an example, we in our economy, we lose nearly 7 billion or so every year due to poor health, and that is people of working age not really being at their maximum level of well-being, and therefore not really contributing to the economy. Not so much maybe of an issue in economies like India, for instance, but it is going to become an issue if you just follow the demographic trend of what is happening in some of the Western countries. So health, the importance of improving health, whilst it's of utmost to the heart of healthcare practitioners, healthcare workers, as a professional issue, it is also an economic issue. It's also a social issue, certainly in the economies like the Western economies that I work in. So we have, in our practice, need to consider the pros and cons of all the interventions that is available to us in improving health. And I'll dwell deeper into that in a little bit more. But this is what I really wanted to achieve today. How do we explore the determinants of health, and what does practice of public health medicine in the UK mean? So you all get a chance to learn about that and maybe relate to your own areas and perhaps connect with public health professionals in the places that you work. And my real motive behind this is to introduce friends to ideas for embedding in your day-to-day practice. How can you take some of this and embed it in your day-to-day practice? Now, I think many of you will already know this if you've gone through the SPM subjects that we've all been through. The World Health Organization actually defines health as a state of complete physical, mental, and social well-being, and not really merely the absence of disease or infirmity. Now, that is quite a broad definition, right? What is a complete physical, mental, and social? Actually, well-being means we see people when they come in with a swelling or pain or with infection or the disease. Our job as health professionals is to find problems, diagnose them accurately, and put a plan together to treat that disease. And there it predominantly stops. But the idea of well-being has been there since in the late 70s, but it's gaining more traction probably 50 years after we knew what actually determines our health. And that is quite late, right? Between new knowledge and how we practice that new knowledge in everyday practice. And it is quite new even for medical professionals, let alone wider professionals, and let alone politicians, for instance, which I do intend to come back to later in the presentation. So if you translate that into practice, public health practice, that is a multidisciplinary field. And in the UK, anybody can become a public health practitioner. It used to be just open for medical professionals. Now it is open for anybody. If you are a medical professional, you obviously can enter into the discipline about a couple of years after your qualification. If you're not, you need to have a longer career experience before you come into public health. But essentially, we deal with promoting that well-being and preventing disease as well as prolonging life. And that becomes a much more societal issue when it comes to prolonging good life and healthy life expectancy and all of that. So before I go further, I want to introduce one more concept, and I'll pause, and I probably will invite two of you, so be warned. Just a few seconds of your response. But this is something like a holy grail for us, certainly in England, when it comes to public health practice. We very fondly call this Margaret Whitehead rainbow, which really is on almost every public health professional chart somewhere on the wall. When it comes to improving public health, this is what we talk about. There are certain things that we really can't do much about, and those are your constitutional factors. Even that now, for instance, gender reassigning is becoming a very topical and a sensitive issue. But there are certain things that we generally consider not modifiable, but it changes with time and usually worsens over time. And then there's individual lifestyle factors, which is what we just talked about: tobacco, physical activity, an healthy diet, and alcohol. And there are many more, including gambling these days is becoming an issue. Addiction, generally speaking, when it comes to broad definitions. But more social and community networks. I mean, this is what I like about our tradition, our culture in India. And it's becoming forgotten, I would say. The role of societal, social, community networks, family networks in generally improving well-being. I think we are rediscovering that in the UK. But as you go out towards the periphery of this rainbow, you'll begin to understand how the variety of things actually improve or influence our health and well-being. And these are very familiar things, right? Who's going to disagree that housing is related to health? And I still remember signing people off, and there used to be 2 clinics every week that we used to sign people off with COPD generally, or TB, on medical grounds. So they retire, and that is associated with poor housing, for instance. Now, I want to pause here, because this forms the template for the work if you really are about improving health and well-being. And that is if you really are working to improve the conditions in which we are discharging people, maybe after treatment, or indeed if you're interested in influencing the wider society. Now, could I, and it may be difficult technologically speaking, Dr. Balavenkat, but maybe put in the chat, roughly speaking, what's people's view about the role of healthcare services, which is there on your right-hand side of the screen, in percentage terms? What percentage of our health do people think is determined by healthcare services? And maybe the host can unmute and give us a guess, or maybe you can put it in the chat. Okay.
We are yet to get replies in the chat, sir.
Okay.
Could you please repeat the question again for the listeners?
The question is, what proportion, or in percentage terms, do people think healthcare services determine our health and well-being? So is it 80% of our health is due to healthcare services? Is it, I don't know, 10%? About 10%, okay. Okay, I'll give you the answer in a few seconds.
Satya Kandasamy ma'am has replied about 10%, and
10%.
Mahesh Kumar Srinivasan has replied 75%.
Yeah, 75%, right, okay.
I think,
so there is
Dr. Shakthi, going by your talk, if you remain healthy, you don't need the healthcare services. When you preserve your body,
okay.
soul.
Okay,
Yeah.
so we go from, we don't really need health services until we get a disease, to 75% from Mahesh. So here is some research on that very subject. And what we know is clinical care, and that is good quality clinical care and timely access to good quality clinical care, and care that is culturally sensitive, contributes to about 20% of our health. Very important, 20%, especially if you're having a heart attack or anything immediately life-threatening. But the point is, it is about 1/5 overall through one's lifetime. And the next thing I want to highlight here is the importance of the social, economic, and environmental factors. You may think, well, what's that got to do with me? I'm an anesthetist, I'm a surgeon, I'm a physician treating diabetes. What has that got to do with me? It's got everything to do with you, I would argue, because of a simple fact that in spite of having fantastic care in the ward, in the clinic, people are going back to the same environment, generally speaking, to the same social, economic, and environmental conditions when they are discharged back. And that is, well, that's not ideal on 2 counts. One, all the good work that you've been trained for and we've been trained for to do just gets completely scuppered when people go back to the same environmental conditions when they contribute to 40% of someone's health and well-being. On the other count, what's the point of good quality clinical care if we can't influence that? And this is something that may not be immediately in people's minds, but I hope that it triggers some thoughts about what might be our role if, with this new knowledge, we were to really improve the health and well-being of our patients or our residents. In my case, I deal with the whole population and not necessarily people who are just ill and sick. The other thing is healthy behaviors. Now, again, is healthy behaviors really in our hands? Can only be answered if you really rephrase the question, to what extent do healthy behaviors in our own hands? I don't know how many of you smoke, for instance, but if you have ever smoked, and I've tried when I was young, the first fag was from somebody else. I didn't go and buy it. And most frequently, this is what we hear from even now young people. It's usually their friends, or they may have seen the family, which kind of normalizes or attempts to normalize a particular type of behavior. And that raises other questions as to, well, am I really in control of my health as an individual? And also the conditions in which, say, cigarettes are sold, or alcohol is sold, or indeed increasingly the amount of fat, sugar, salt that we have in what is becoming a bit of a problem in terms of unhealthy diet and the role of more processed food. And it's a nightmare actually to address that in environments like the UK, where regulations, and this is the role of the government generally speaking, regulations are becoming weaker and weaker, and markets are becoming stronger and stronger, and it is very convenient for people to add a lot of additives, increase sugar, extending the shelf life, and people aren't generally aware, and these kind of foods tend to be more tasty, and it often starts very early. And the physical environment too, like air quality, for instance. You can't be argued that it is entirely in someone else's personal hands. And this, friends, is the core that forms the public health agenda, which is indeed a social agenda, an economic agenda, environmental agenda, particularly when it comes to climate change, for instance, is the single biggest threat that humanity faces, and that can potentially wipe out the entire human race. And that's the kind of agenda that is in front of us, and we, knowingly or unknowingly, are part of it. And I'd argue we need to A, be aware of it, and B, wherever possible, in our own ways, try and do something about it, because that's at the heart of medical practice. That's the heart of doing no harm, and at the heart of more equity and practicing a high quality medicine. So we are coming to nearly through the presentation. this is how it works in practice. And I'm going to show you a couple of examples, and we will pause there for a bit of a discussion on what it means. So when it comes to improving health, unless you have a much more nuanced answer to the question, is our health really in our hands? And the answer is yes, but, or yes, and. It certainly needs access to high quality care, but we've seen already it's about 1/5 of what determines health and well-being. But the bottom two, particularly the one on the right, fully engaged citizens. Fully engaged citizens in practice, meaning citizens that are completely fully aware of what determines their health, and not just understanding, yeah, smoking actually is harmful to my health, or gambling is harmful to my health, but what about the social networks that we're fully part of? And can we mobilize communities to actually understand and help and reframe the definition of health in people's minds? To a large extent, and we do surveys and there are lots of research on this, when you go and ask people what will make a biggest difference to your health, people generally tend to say, well, I want to see my doctor. And this is not quite the case in India, I have to say this, but in the UK, for instance, I want to see my doctor the same day. And that is what is in people's minds, not, well, how is my living condition? Am I really having the opportunity to go and do exercise as part of my daily lifestyle? Do I have access to fresh food, or is the packaged foods got more oil and sugar and salt in it? These are not what is in people's minds, and that, as we've seen, influences the health and well-being of our residents quite a lot. But they may not be able to do much about it, especially when there's no choice, but they can be more aware of it. And that is becoming a trend here, certainly, about public engagement, mobilizing communities and raising awareness so that they're all helped to consciously think about what determines their health and well-being. And on the bottom left, the health promoting social, economic and environmental policies. This may not be in the forte of everyday practicing clinician, but it does influence them in a number of ways, ranging from taxation, ranging from the regulation of care that you provide, as well as the wider social policies. So just to give a couple of examples in the UK, and increasingly we are seeing a lot of U-turns from the part of the role of the government point of view. There are existing measures, for instance, duty on alcohol, duty on tobacco, they're all being reversed. And we have seen in the past when smoking regulations were introduced, so smoking in public places are essentially banned, it's illegal in the UK, we've seen a drop, we've seen an improvement, actually, a drop in heart attacks and an improvement in cardiovascular disease, but then it's now being reversed by obesity, for instance. So we say obesity is the new smoking, and it is on the rise, and it can wipe out the entire budget of the NHS just by treating diabetes. And we are seeing people, I've just been to a dentist this morning, there was a notice saying, well, if you're over a certain kilogram, you need to let us know because our systems can't hold you. And ambulance guys tell us, you know, people are sometimes, we're struggling to fit people into the ambulance. And that kind of policy is directly going to affect us. Climate change policies directly affect healthcare. One example, and we've seen this in the UK this summer, we are starting to see extreme temperatures. For instance, we've never seen 37, 30. I mean, this is normal, right? In India, it's normal. But what I mean here is extreme variations. If you have a constant sort of pattern, generally speaking, systems are well adapted. For example, air conditioning is quite common in many countries, but not here in the UK, you know. And if you can't maintain a certain temperature in, say cold chain or say the theater, we are done. So these things quite often are taken for granted, but in the background, they are being slowly eroded by sort of more liberalistic, deregulatory policies, and the role of the government is getting smaller and smaller, and people aren't really fully aware of it. And people like us, some of us, are worried about it because the way that the world's going means that everything is very individualistic, and there are pros and cons to everything, so don't get me wrong, but what is the common good? Is health a common good? And if it is a common good, what is our collective role in it as citizens and professionals? Are we simply going to be providers of individual care, which is very high quality and very accessible, or are we simply going to be consumers of care, or generally consuming citizens, where we don't really have a say or choice really in what we buy, what we eat, where we live, what's the air quality like? Or are we going to be more engaged in the wider agenda of improving health? And that is the question I'm posing, and that's the question we all face as health professionals. So the way that we're trying to do that is, I'll end in a couple of slides. The first thing that we're doing is really fully engaging our communities. And it is very hard, especially with the media, the ads, and with the rhetoric, which is all about access to healthcare. It's very hard to actually get this message and engage public about what drives your health and well-being. But there has been some fantastic research done in the past. The New Economics Foundation has, over a couple of decades, done a lot of research, and they basically said the way to describe and engage public is make it really simple, make it really accessible for them to understand. Don't over professionalize it. And they've come up with this thing called 5 ways to well-being. Volunteer, that is give. That's on your left-hand side on the slide, by the way. Keep learning, keep your brain active. And we have seen that this can possibly postpone the onset of dementia, for instance. And indeed, mental health, all of this affect both physical and mental health, by the way. Keep learning, be active. We know by being active, even if it's walking, it doesn't have to be going to gym every day. It has such a positive effect on our health and well-being. And taking notice of your own self, your body, your thoughts, as well as what's happening around you, and being a bit nosy about what's happening in the community by connecting with each other. So this, what we used to do, and I think we still used to do, maybe it is going down and disappearing in even places like India, but this is now, there is a greater awareness, and increasingly health professionals are actually prescribing these activities. It's called social prescribing, as it says on the slide, to be part of almost everything that we do, whether it's mental health, surgeries, preparation for surgery. We saw that the other day. There's a whole thing about perioperative medicine and how do you prepare people for surgery, and indeed the long-term conditions that we treat people with. There is a whole range of peer-to-peer support, recovery-led communities. I think there is a great market in doing this in the right way, even in India, if you ask me. And then the final part there is a real emerging trend, is the power of internet and mobile phones that people have incredible access to these days. It's an avenue that is a double-edged sword, if I will. There's Dr. Google always, and that's the danger hanging over our head. But done in the right way, people can be empowered with information, access to good quality, direct access healthcare, as well as the networks of people who have similar life experience with health. So this is some of the things that we are doing in the UK that I wonder whether it is applicable in your day-to-day practice. And there's a lot that's been researched in the policy area as well. And I'll end with that slide. Nobody working in public health won't know Sir Professor Michael Marmot, who is actually a world expert. He used to be the president of the World Medical Association. He's done and with WHO has done a lot of research on health inequalities in particular. And the research and the work that the Institute for Health Equity has done has shown us a few things that professionals working in healthcare can do to get engaged in this wider agenda. Daunting may it seem, we argue that it's the need of the hour and the need of the day. And these are the 4 things that we're trying to focus on. I wouldn't say we're entirely successful, but we are trying to focus on. And if you are in positions of leadership, I encourage you to think about this as well. How do we educate our workforce and train them to be picking up signs of those wider factors that affect their health? Do we routinely ask what jobs people do and think about how that may be affecting their recovery? And the lifestyles which we commonly do, I understand, but really, do we have support for smoking cessation, for instance, or addiction, for example? Practical actions. I've shown you a couple of things, like the social prescribing, like the 5 ways to well-being. There are so many other things out there too. And if anybody's interested, I'm very happy to link people up to tools like shared decision-making, self-care management tools. And then the third one, really, I'm not entirely sure how this works in every country, but certainly making friends in other sectors in the local area. It may be your principal of a college. We can go and give a talk about mental health, for instance, or somebody working on the roads and transport policies, that working in respiratory medicine or even endocrinology, for instance. You may not have thought about that, but we're trying to connect people up. And it is difficult given that the workforce is already very busy and there's demands going up. But we see this as an essential part of if we were to have a sustainable health system and improving our health of the residents, this is important. And then the final one is advocacy. And this is where we enter into politics and policies more than politics, although politics is, I'm sure, very entertaining. The thing that I focus on is policies. Often see a lot of politics, but very little policies that will improve health. And that, again, as health professionals, we still have a very high rating and respect in our society, and our voice does get heard, but we probably aren't mobilizing and networked enough, and maybe not have the time to think carefully about influencing national policies. And these are the things that we're doing, and I'm sure lots of places are doing the same as well, in really bringing back to our health being in our hands. I do think our health is in our hands, if you ask me now, but it is not in any single person's hands, it's in our collective hands. And that can be improved by having the will and the power. So I have described the health and what determines the health, and exposed you to how we're dealing with it in the UK, and also given you some food for thought about what you can do in your own roles to improve health and put health back in our hands. I look forward to speaking to you and answering any questions you may have, and thank you.
Thank you so much, Sakthi sir. Definitely the health is always there in our hands. And before we proceed to the question answer session, I would like to invite Dr. Ramalingam sir, who is joining from Tanjavur. He's the co-chair of the academic committee to propose the vote of thanks. Sir Ramalingam sir. Kindly unmute, sir. Ramalingam sir, kindly unmute and speak.
I've unmuted. Can you hear me now?
Yeah, you're audible, sir.
Hello,
Yeah, we can hear you, sir.
Good morning, good afternoon, and good evening for global alumni doctors. And special thanks to Dr. Sakthi for covering this difficult topic. Not everyone can talk the way you are authentically talking, and especially healthcare and patient relations and our healthcare with the business interactions. All these are something different for us and difficult to practice also for us. But you made a very, very clear remark about all these things. wonderful talk. Thank you so much for taking time to share it with us. I'm halfway through in a meeting, Sakthi and Kannan and Balavenkat. Thank you for this nice interaction. Please carry on with the question and answer, Kannan.
Thank you.
If possible, once I finish my session, I will again join. Let me see.
Thank you.
Good luck and thanks.
Thank you, sir. Now we request the participants to, Madhu, sir, you want to speak something? Yeah, please go ahead and unmute and speak. Can you unmute yourself or should I do it? Yeah.
Oh, yes, I got it unmuted. Yes. Sakthi sir, fantastic. It was an excellent to listen to you. I have a question. Currently in India, people's health is actually determined by a commercial market. People who speak about say some products that enhance health and things that are sort of not in the control of people at all. What do you think? What would actually control the health of people in future? Is it the market driven forces or education from doctors that will actually control? I feel doctors actually have no role in public health, at least in a setting like India.
Yeah, a nice question, Madhu. Not very easy to answer. I think I'll begin with the way to approach this is if you think about how we've arrived where we've arrived in a commercial market-based healthcare where it's quite transactional and often very episodic. You get your hips done in one hospital, and if you have a chest pain, you go to another hospital, and the continuity is often not there. And people's minds are really concentrated on the here and now, and they only start to think about it when people are ill, not when they are really well. And maybe healthcare professionals' roles is very difficult to achieve here, but it'll, in my view, we need to raise awareness. We need to have these debates and discussions in public with the public, and it will only happen over time. You can't change it. But fundamentally, it's about each of us as citizens. I think we have become more of a market-based society. A market-based economy is fine. We need the markets for the economy, but actually markets have really encroached our society much more deeply, including healthcare. And it'll only come with education right from the beginning, particularly education of health and care professionals, but even more importantly, education of policymakers and how the implications of making policies in one domain can affect adversely in other domains. And ultimately, it's a democratic thing, right? Ultimately, the way that things are determined in our society is based on what is law, how much tax, who controls what, and the power of information and media. So I think it's much broader than, although it may seem very close to our heart in terms of health and medical practice, it is much, much broader than that. And I'm not sure whether the medical profession is organized enough to even have these discussions, because we are, in effect, put in a box, and we need to start thinking about beyond the walls of our clinics and how people actually live their lives.
Thank you, sir. And we've got a question in the chat. Ramamurthy sir has asked, what percentage of population in UK who can reach high quality care?
So it's a very difficult question to answer, sir. But pretty much, not everything, pretty much everything is free in the UK. Some of us pay for prescriptions and dental care. Emergency care used to be fantastic in the UK. Now we have seen ambulance waiting times increasing, for example. But it really depends on which part of the health system you measure, sir. So primary care is what is delivered by GPs. And I would, in summary, I would say some of the more life-threatening conditions and how we care for that in the UK, pretty much everybody mostly gets that kind of care really well. But when it comes to managing long-term conditions like diabetes, like heart disease and kidney disease, long-term conditions which require continuity of care, it is getting worse actually. And that is not being helped by lack of workforce and lack of workforce planning. So you may think from wherever you are, UK is one of the best, and I would like to say it is one of the best, but actually it isn't the best of the best in every domain of healthcare. So it's a very difficult question to answer, sir. But I've been in India recently, and what really surprised me is how much improvement have been made in access to fantastic high quality healthcare in India, and generally speaking, the infrastructure. So I do have, I'm fortunate to have that kind of comparative thing in my practice. So I can say that don't underestimate, and I'm sure we're not, but there are some really fantastic quality care in India as well. Go on, Madhu. Unmute.
Unmute. 1 second.
Thanks for unmuting. Dr. Shakti, just like how Dr. Ramurthy asked, high quality healthcare is available only for those who pay in India. But then it is accessible to some people for free in the UK. But then to access high quality primary care, it's not available in India at this point, because the primary care is still lacking, because so many places where people can't travel or the primary health centers are not functional, etc. That care is probably better in the United Kingdom than here in India.
Yeah.
But then good quality care for people who can pay is really accessible in India. So that, top say 10 to 15% of population which can afford medical care, it's extremely affordable in India. But then in the UK, it's quite unaffordable for those also who can still pay.
We haven't reached a state, Madhu, in the UK where we've asked people to start paying for their medical care. But you're right, rural parts of India, people who can't afford to pay for the high quality care, it is a struggle. And I haven't really looked at the statistics of that to be able to give you a complete answer, but I completely accept what you're saying.
From oncology perspective, which I deal with, only about 5 to 15% in India can actually access good healthcare. It might appear very small, as in 85% don't access good healthcare. That's because several people from villages, people who can't afford treatment in big cities, are actually deprived of healthcare because of so many factors.
But the funding, it all comes back to, Madhu, where paying from your own pocket is the main way of accessing healthcare. In those countries, you tend to see such a wide variation in access, where the governments, the state has actually stepped in. I wouldn't argue in every country where government is stepping in, they are providing universal healthcare of good quality, but certainly in the UK, which is one of those countries, you tend to see, broadly speaking, really good access, compared to many other countries. The problem is when it comes to state financing, and we just had our mini budget yesterday, the governments have taken an approach where they're going to reduce the tax take, which is good if you're a high earner, if you're a wealthy individual, and reduce. Basically, the role of the government is becoming smaller and smaller, and our debt as a nation is increasing. And when that debt is increasing and taxes are reduced and the cost of borrowing and the inflation is going up, how are we going to continue to pay for public services like the NHS and still maintain high quality care is a big conundrum for places like the UK. And that's where the role of prevention and the role of self-care, can we take our health in our hands, become a more important question.
Fantastic, sir. Thank you.
But I do hope that as individual practitioners, you had one or two things from this presentation, although it may seem very daunting and monstrous. You took away one or two things where you can, at least at an interaction at an individual patient level, you're at least more aware of what may be happening in their lives and be able to do something. Dr. Shan?
Shanmugharaj sir has a question. Please go ahead, sir. So you have to unmute, sir.
All right. Okay, thank you for the enlightened talk, Sakthi. I never missed your talk, but today I just joined in the middle. I'm sorry about that. As usual, you were brief and you touched the valid points. I think my take-home message from your talk is policymakers. I have to underline and highlight this: policymakers, politicians. Unless the drive comes from the government, central, state, and corporation, if it's a city, through healthcare, it's not easy to educate the public. I know we are achieving some success, like prevention area, we're giving vaccines, and then teenage, we have to prevent all these social media issues, and then adulthood, dieting, exercise. Somebody has to tell the public. It's only the government they will listen to. So it's a government-driven program. We need more, especially in India. Well, I have given a talk both in UK, Europe, USA, and India, Chennai. Now, what I observed was people listen to all the speakers in Europe and USA, but Indian audience, when the health, they listen to all the banking, business side, corporate side, they are very quiet and listen to people making money. But when it comes to healthcare topic, they go out for a break. Absolutely challenging for a speaker. So in Chennai, 2016 Chennai, I have to tell the guy who was running it, you have to get the guys back. So I stopped my talk 5 minutes. Then they brought most of the people back, and then I proceeded. So this is the problem in India. Education has to come from, well, doctors can do, people like you in public health, but the specialists, GPs can do some extent, but the hospital practitioners, they haven't got a time and they haven't got remuneration for doing public health. So my feeling is, just a comment, my feeling is the drive has to come from policymakers, politicians.
Correct,
thank you.
So correct. We all are very familiar with PPE, and I often say that there is another PPE for improving health, not your masks and gowns and gloves, but actually the politics, the philosophy, and the economics that really need to underpin all of this. And actually, in some areas where the role of the government is diminishing, it's not all. Yes, the government has a very significant role, but when the role of the government is being shirked or diminishing, the society operates and it evolves through increasing the role of the citizen, and indeed the markets. But quite often they put a wedge and they become more unequal society when it comes to wealth, and that's not good either. So yeah, it's an interesting subject, isn't it?
Yes. Yeah. Instead of starting medical colleges in all the districts, they should concentrate on public health care. Thank you.
So, sir, we are getting a lot of congratulatory messages on the chat.
Okay, pa. Dr. Nagmala is asking if you could unmute the participants to ask questions. I don't know who can unmute all the participants.
Savita,
yes, I'm doing so.
Yeah.
So now everyone can unmute themselves. So now everyone is muted. Now unmute. Yeah.
Can I go for the next question if there are some time available? Shakti, excellent talk as usual. Fantastic. There's always something that I can learn from you, either speaking on the phone or attending your presentation. So thank you for sparing your time. So my question to you is, isn't it the human mind always have the curiosity of trying out something, whether it is good or bad, despite knowing everything, and then later realizes by their own mistake or seeing others' mistakes, right? Having said that, they know that, oh, healthy behavior is such and such, and we, even as a healthcare providers, at times wish we could have done better that day, right? So giving that background information, you as a public healthcare professional with your holistic approach, what challenges do you face? Number one. And then the second one, with all the limitations that we have in different parts of the departments, right? Let alone the politics, the policymakers, as a provider who has no direct contact with the public health, but as an individual provider, when I see the patients, how can I put that seed in their mind and then make it hopefully grow and then flourish? So those two are my questions.
Well, I'll keep it very brief. I mean, this is a PhD topic. How can human minds, knowing everything, go back and do the same thing? I'd argue, well, we may think we know, but maybe we don't know. And also, we may know, but we forget when the sweet or the fag or the booze is right in front of us, and we postpone something else for the immediate gratification. I think that's a really difficult one, and that is basically the human condition. So I wouldn't go into that, but it is the way we've evolved, and sadly, good health is only appreciated when that good health isn't there anymore, quite often. And I think that's the challenge that we face. And maybe there's no such thing called perfect health, and there's always going to be a preponderance of providing healthcare when you need it. But in terms of day-to-day practice and what we can all do, there is definitely the role of education and maybe opening the eyes to the public that, common things. And this is something that we've learned. I mean, even Thiruvalluvar has said, right? Knowing Nadi, knowing Mudal Nadi, and so 5 things, sleep, eating, moving, relaxing, doing things that you can do, and highlighting the importance of that in every patient contact. We call that making every contact count. So that's the kind of thing, as individual practitioners, we can all try and incorporate that in our day-to-day practice. Naga, I think that's it's a conundrum. And I think if that has been solved, we wouldn't be in our jobs, right?
There's only so much that goes into the ear and to the brain, no matter how much lecture you give. But thank you, Shakti. Thank you.
Sir, we have a question again from Ramamurthy, sir. He is
sir, about budget allocation.
Yeah,
sir, UK, sir, India, I wouldn't claim any expertise, sir. I'm a bit ashamed to say I've not been following the allocation in India. But in the UK, I would say the budget allocation has got 2 components here. One is the allocative, so between sectors, how much you allocate in health sector, and within that, how much in the NHS, how much in social care. I think there is no plan, if I'm being honest, about the workforce, for instance. So it is not quite often just the money. It's what do we do with the money as well is a bit flawed. But then there is also something called technical efficiency of the allocated budgets. So we have views about per head of the population, or for treating respiratory illness, how much budget we allocate. And if you look at it, more or less, most of our money is spent on reactive healthcare and not really proactive healthcare. And by that, I mean, we can reach people who are at risk of a crisis, whether that is kidney disease or heart disease or whatever system, and we can intervene a bit early using the technology, certainly these days. But that's where this is all going in terms of allocation. We can never take the role of the individual human interaction including AI, for instance, but we can make it really easy for people to access good quality care. And that's the kind of budget allocative discussions that we are currently having. But ultimately, there's not enough people to provide healthcare in the current sort of state of play, and the demand is going up. So something has to give, or we'll have to go through a real dip in our health outcomes. And I reported, for instance, for the first year in my 10, 12 years of being in public health, first time I reported our life expectancy has gone down. And this is never heard of since the war, Second World War. We'll see, sir. It's a really difficult situation when it comes to budget, but it's not all about more money. That's what I want to highlight here. And it's not all about more money in health system either. If we can educate people well, if we can do proper housing, if we can improve the transport infrastructure and the air quality, they have direct impact on heart disease, for instance. If you can regulate properly, we can actually influence tobacco, drugs, sugar, but that needs politics as well as policies.
I have some information on that, Sakthi. Correct me if I'm wrong. In US, they spend 14% of GDP for healthcare.
Oh, yeah.
Germany and Sweden, same 14. UK, 11%.
11, yeah.
But India, only 1.52%. So that's way down.
Low. But in India, the state is, I have to look into it, sir. The overall spend of the percentage of GDP we need to look at, not what just the state invests in. But you're right. Definitely in India, we need more percentage of GDP spent on budgets on healthcare. There's no doubt. There's no two ways about it.
Correct. So the government is overlooking. So the public is overlooking the health.
Chandra sir is raised his hand. Sir, hope you're unmute. Please go ahead.
Thanks, Sakthi, for interesting, thought-provoking talk. And also thanks to Balavenkat, Ramalingam, Kannan, Dr. Gupta for starting the education program again. And also, I think we need to make sure that there is more publicity of the speaker's topic to the students and PGs. I think the people who are logged in are alumni. I think we want to have more interaction with the faculty, students of educational events. So hopefully, I think, now that you started the education webinars on track, so hopefully it will improve. But anyway, so thanks, Sakthi, for an interesting
Thank you,
talk.
sir.
Thank you.
Thank you, sir. I would like to invite Kumar Gupta, sir, the president of the Alumni organization, to give his concluding remarks before we wind up.
Shakti, thank you so much. It's been a pleasure listening to you, and it was a privilege meeting you here when you were in India and spending some time with you, exchanging notes on various aspects. So thank you once again. And I must thank all the participants for having actively participated and asked various pertinent questions, which Shakti, of course, answered to the full satisfaction of all of us. So that's about it. I thank you, and we look forward to the next session, which would be sometime next month. I'm sure Bala would give you all the information on that. Thank you, Shakti. Thank you.
Thank you, sir. And the video recording of the presentation will be available, archived in our YouTube website. It will be soon circulated in all the WhatsApp groups and other social media platforms. Thank you so much.
Thank you.
Chandra sir wants to come in.
Well done.
Thank you, sir. It's been a pleasure meeting you all. I wish you all the very best.
I don't want to come in. I just want to say goodbye. Thanks.
Oh, okay. Bye, sir.